Please see the mic is working for the
Hello,
speaker,
hello, hello.
please.
So I think very nice talk by Dr. Mishra. I mean, taking it beyond the advanced monofocals. So presbyopia correction beyond the rings. We all know that, and we all are actually suffering with this nuance, the presbyopia. Now the goal is to have a full presbyopia correction. Actually, the first talk, what actually spoke of the lens, which has no glare halos and gives you vision at all the three, is what is actually the need of the industry and the need of the hour with high quality vision. So we all know the IL treatment options available in market, the multifocals, trifocals, and the EDOFs. Now there are two aspects to the presbyopia correction. One is the quantity. So quantity means the spectacle independence, the improved near vision, and the second is the quality. So negligible photic phenomena with a very good contrast. Vis-a-vis the trifocals, there is a little amount of glare, there can be halos, starburst, ghost images, and the decreased contrast, which actually we are all as practitioners very, very apprehensive giving these to those type A or critic patients this kind of support. So when I have these trifocal patients sitting on my chair, I would always ask them, I mean, they would come with their complaints and they would always draw. And this is the type of picture they would draw. So I actually differentiate between what a halo is and what a glare is. This is what they would draw whenever they say this is a classical halo. This is what is a starburst when they draw it in the form of a star. This is against an alternate halo, and this is what they would draw, and you call it as a glare. And this is what actually makes us apprehensive in patients who are keen in driving, who are lawyers by profession, who are actually very critic or a type A personality. So then comes in the role of what is the EDOFs, but actually does EDOF give you a true spectacle independence, or there is still a gap in the near vision, though there is no dysphotopsia, and these lenses are very quick in giving you that kind of a neuro adaptation. So there are certain unmet needs in the refractive cataract surgery when you talk of quality and the quantity. Now the concept of EDOF is very clear. You are basically adding some amount of spherical aberration only in the central part of the pupil, increasing the depth of focus to overcome that presbyopia without actually leading to the poor night vision. But yes, none of these EDOF lenses actually qualify into that perfect EDOF lenses. A lot of studies published, literature collected, actually demonstrates a good range of vision, good distance, good intermediate, and an average kind of a near performance. But when you have a patient with bilateral implants, the patient actually fares well. But what is more important is a very good contrast and a good dysphotopsia profile with most of these EDOF lenses. Various studies comparing a lot of lenses, but we came up with our own the Minivel lenses. This is one good slide that I had actually look in. Whenever you have a small amount of refractive error, whether you err on the hyperopic side or a myopic side, most of these lenses, you see the profile. So if you have a multifocal, even a small amount of myopia or a hyperopia could lead the patient to this kind of a dysphotopsia. As against, you have these monofocal IOLs which are quite balancing, and the advanced monofocal IOLs which are quite forgiving. And to a certain extent, the EDOF lenses are also forgiving for small amount of refractive errors on either sides. Now, choosing the lenses actually needs a quick workup, and we all know that the workup we have all been doing, but what is actually important in my experience is a series of 96 implants of Minivel that we did, 29 bilateral, and most of these patients were very happy. Bilateral patients are very happy for distance, intermediate and near, no dysphotopsia, and good contrast. And only 2 of the patients which actually came up with a very early phimosis in the first 15 days was very surprising. And one of the patients usually had a photoptic myopic shift. That means the patient came up with a typical complaint of fall in vision whenever the patient was driving during the daytime. So pupil, I again reiterate, is a very, very important factor whenever you are trying to choose your premium IOLs. So pupil size mesopic more than 2.75 is actually mandatory. So whenever you are actually counseling or taking these patients on these segments, or whether you are choosing a trifocal or a EDOF, you actually have to give a small chair time on looking onto the pupil dimensions. Anything less than 2.75 is actually wrong. So we went back and saw the pupil size. The patient had a pupil of almost 2 millimeters, and that is what was disabling. So we did a lens exchange, but most of the patients actually fared well. I'm just sorry, I think the slide got stuck. So this is the whole concept of the Mini-Well. The optic of the IOL has actually 3 distinct areas where there are different spherical aberrations are applied. This is the zone 1, the zone 2, and zone 3, where you have the plus spherical aberration in the center and the negative spherical aberration, and then again a positive spherical aberration. And this is actually what gives you an extended depth of focus in most of these patients. So as compared to the trifocals, there are no glare, no halos. It gives you a good contrast, and there is definitely better night vision. And as actually Anurag said, the light transmission in most of these patients is almost close to monofocal. So if you see here, this is what actually translates into night vision, and this is with most of the trifocals and the EDOFs available. So this is how the depth of focus and the night vision would actually look into. So this is the defocus curve with the Mini-Well. If you see here, I'll just take a minute here. So this fares equally almost as like a trifocal, but yes, onto the near vision there is a slight fall. A quick combination, what they suggest is a combination of Mini-Well and a Mini-Well Proxa, where they have a spherical aberration distribution in the opposite side. The number of zones actually increase in the Proxa model, and which is usually can be taken in the non-dominant eye, and a combination of the 2 lenses would actually gives extended depth of focus, which is something like this on the far distance and intermediate. So this is a combination of something like a mix and match of Mini-Well and Mini-Well Proxa. The Proxa goes on to the non-dominant eye, and this actually gives you a better near vision in the non-dominant. So combination of the 2 actually transforms into crisp distance, intermediate and near, with a good contrast and a good quality in good light quality in all lighting conditions. Negligible incidence of dysphotopsia in our study was observed, and thank you very much.
Thanks a lot, Dr. Sonu Goyal. Excellent talks, both of them. Very nice. Any questions from the audience? We can take 1 or 2. Yes. One that Dr. Mishra, yeah.
So, I think one is talking about the spherical aberrations in the center, then the negative spherical aberrations, and then again the positive. So there are basically 3 zones. So with most of the advanced monofocal IOLs, I think it's a uniform blend of the change in the spherical aberration right from the center to the periphery. Correct me, Anurag?
I'm actually not sure how because aberration is something that is on the image side. It is not something that's on the IOL side. I'm not very sure how spherical aberrations are added, or even negative spherical aberrations are added. Instead of flattening the surface, what do they do with the center so that the aberration profile is added on? But what sir is saying is basically right. So if it is a free-form optic, if it is something that's got anything to do with the surface change, then things appear similar. But I don't know how the aberration, but it is true that the aberration is on the image side, not on the IOL side. So what do they do on the IOL side to produce that aberration on the image side is something.
So on that Vivity platform, we see that slight bump on.
That's a wavefront reshaping thing.
Reshaping,
so completely different from just adding on aberration on the image side. That doesn't add any aberration. It focuses and then it stretches the wavefront so that it becomes a line. That's a completely different technology.
But most of these EDOFs would play in and around the spherical aberrations.
The interesting thing is, since we are in any of these IOLs, if we take, the central ring is what is the central zone. Though we don't call it a bullseye, but there is a central zone which is pivotal to the IOL's function. So I don't believe any of these IOLs is free from decentration. They are sensitive to decentration. If you do not have the angles within the permissible limits, you can't implant these IOLs and expect to get optimal results. So they are not universal IOLs, none of them.
So that's what I said,
So
that
no.
you cannot consider them to be equivalent to a monofocal, and you can do in all the patients.
Fantastic discussion going on, but we are short of time. At the end of the session, if you have time, definitely we'll discuss this.